Item number 1, presentation to the court by Hamilton EMS. I believe Patrick, Mr. Cobb is here. Mr. Cobb, would you, let me say also, Michael, you told me that you was gonna post that you was just gonna have a quorum of your board present. No action be taken, but you can enter in discussions, ask questions, things like that, right?
Correct.
And that probably was done, so we're good to go. All right, sorry, Mr. Cobb.
Good morning, everybody. Good morning.
Would you make sure that your mic is on, that the red light's on, it should be on?
Test, 1, 2.
And we thank you.
All right, first I want to thank everyone for allowing me the opportunity to come speak this morning. Again, I am Patrick Cobb. I'm the Director of EMS for Hamilton County Hospital District. We provide EMS for 5 counties in Texas, starting south in Hamilton, and then Mills County, San Saba County, Llano, and Lampasas County. All total about 4,500 square miles, about 70,000 citizens on those 5 counties. The current situation this morning, and I want to start here, then we'll work backwards if you choose to do so. So we received a written mutual aid request from Somervell County Hospital District for ambulance support for transfers on May the 11th. On May the 12th, we began providing that service. We're doing so from our closest station that we have to Glenrose, which is in Hyco, Texas, 26 miles away. So with that, we have a 30-minute response for any request for transfers out of Glenrose Medical Center. With that, in the last 11 days, we've transported, we've had 12 requests for transfers, and we've actually transported 10 patients, last being about 1:30 this morning, I believe. Out of those 10 patients that we've transported to were truly emergent transfers, emergency transports to Fort Worth. One was diverted to a cath lab, and another was diverted to a stroke center during those transfers. The mutual aid request that we did receive was very specific to transfers only, had nothing to do with supporting the fire department to the city or the county as far as emergency response. It was truly just dedicated to transfers out of the hospital, and that's all we've done so far. That's the second mutual aid request that we have received from Somervell County in the last 12 months. We were here for a week last summer during the Chalk Mountain fire, where we provided 2 ambulances, command post truck and a generator to the fire for that 8-day period. So this is the second time we've responded mutual aid to Somervell. What we're doing today has not required a written agreement. There's no contracts, nothing like that in place. It was truly a written request for mutual aid, and our hospital district accepted that request. This current model can, in theory, go on indefinitely. Again, there's no contract or agreement that got us here other than the request. And if we're happy with having a 30-minute response for 26 miles, we can continue to provide the service that we're doing as is. There's a couple of caveats to that. If this does continue long term, it's not a dedicated truck to Glenrose Medical Center in Somervell County. You know, us sending our resource here is dependent on our local call volume in the other 5 counties that we support. So I hope everyone understands that. It's not dedicated to the hospital. And in one of those declinations that we had to make, again, we had 12 requests, we transported 10, and one of those we had to decline because of call volume in our own 5-county service area. So again, it's not a dedicated truck. For us to continue the service and be guaranteed, obviously is going to require some type of agreement, contract or so forth, between the hospital. In my opinion, it's a 3-way agreement at a minimum. My hospital district, your hospital district, and the county would have to be involved in crafting that agreement. And at some point right now, we do not have an agreement which is called a payer of last resort. And for those that don't know, that is an agreement between our hospital district and Somerville's district to provide some type of payment in the event we pick up a patient that has no ability to pay the bill. And that's a very common thing in EMS, but obviously as our own hospital district, we can't subsidize EMS or ambulance support of another hospital district. And I think that's pretty clear. Any questions so far on what we're doing today? Long-term solutions. And this is where it can get, obviously the emotional part of the discussion is what happens long-term. I'm a taxpayer here. I live in Glenrose, Somervell County resident. And my first option A for a long-term solution is for the fire department to have 2 ambulances and perform all the transfers themselves and keep it in-house. Spend local and keep it local. That's my first suggestion. I know there's a lot of discussion about the fire department and transfers, but as a taxpayer, that would be my first option as a solution. Just to give you an idea, we reviewed the first 6 calls for patient revenue purposes for our transfers, and I shared that information with the hospital district. And so they're well aware of what the revenue attached to these transfers are. But in 6 transfers, we generated almost $17,000 in net charges and collected over $8,000. So in 10 transports, we're $30,000 in actual revenue in 1 week, 10 days. So that's $30,000 a month in actual net revenue. And of course, it takes $55,000 to $60,000 of gross charges to generate that revenue. But $30,000 a week in real revenue, multiply that times a year, and you're almost touching $500,000 in revenue that we're not collecting here locally for performing a service here locally by dedicated trucks that have a local response and not have to wait 26 miles or 30 minutes. That's option A. Option B is obviously you have to outsource it. I'm nowhere near prepared to provide a presentation as to what an outsourcing contract would look like. You know, my suggestions to the court are to select that whatever menu you choose. You can do that with an interlocal agreement between government entities, being a county and a hospital district. If it was us, on the other end, it's most common to put out an RFP and actually do a true selection process for a long-term solution. That way you give everybody the opportunity to put in a proposal with a defined level of service. I think it's one of the issues also, excuse me, that's impacting this discussion now is right now there is no written agreement with anyone, whether it's the hospital district, the fire department, the county. There's no guaranteed set level minimum standards of service, no key performance indicators, nothing. And without some type of written agreement in place between the parties, it's just going to be a continuous he said, she said. You know, we're not going to solve anything by not having some type of agreement, whether it stays with the fire department in the county or whether you outsource it. There's got to be some type of written agreement to define those key performance indicators. So option A is to keep it in the city and the county, spend local and keep it local, generate the revenue, do the work to do it. Option B is outsourcing, and like I said, that's a major undertaking to put out a bid on the street and actually select an EMS provider. And when you do that, then you have to question the validity and necessity to keep EMS within the fire department, or if you contract all of it out. And that's a emotional discussion to have. So anyway, that's what we're doing this morning. That's how we got here. Again, we can keep doing this indefinitely, but realize it's not a dedicated truck. We have already had to decline 1 transfer already. There will be more in the future based on our own call volume. But that's where we're at.
So if the county were to decide at some point to go out for RFPs, and we have Texas EMS next to talk to us, then everybody would have a fair share to discuss, talk, issue proposals, so forth and so on.
Yes, sir.
All right.
And during those discussions, that's when it becomes exceptionally public as to the cost of those services.
There you go.
Obviously, you're going to get the weeds of cost.
There you are, yeah. Because like you said, you can't continue this forever with the hospital. We understand that. All right, any questions at all for Mr. Cobb? All right, thanks, sir.
Thanks, sir.
Appreciate it. Item number 2 is presentation to the court by Texas EMS. Mr. Reeves. How you doing, Ricky?
Morning, Judge.
How's things going this morning?
Busy.
And so everybody knows Texas EMS does a lot of backup. Correct me if I'm wrong, Michael, or Dr. Bosnick, does a lot of backup for transfers right now also. Sometimes not always backup, sometimes you're the ones that do the transfers.
Yes, sir.
But anyhow, sorry, go ahead.
Good morning, everyone. My name is Ricky Reeves. I'm Executive Director of Texas EMS. We're 15 miles away from Glen Rose. We've been doing transfers for Glen Rose Medical Center for the last year and a half. We were approached April of last year to come and do that by CAT. We did as well. We do not have a contract as well. And we've been transporting ever since as the primary transfer service. Like Patrick mentioned, I have a busy 911 service. We have 4 trucks that we use in Hood County, and we utilize that truck when it's available to company transfers. I do have the data for the collections. I can tell you in 22 we collected $150,000 out of our transfers. So I'm not sure where the numbers come from with Mr. Cobb, but it's not as lucrative as it looks. A lot of those were non-payers, did not have insurance, did not have Medicare, Medicaid. I think when your tourist activity approaches and you have those patients, you get a lot more patients that don't have monetary means to pay for those. We were asked to come visit with the judge about a month ago. I did not realize the heated discussion that had been going between the county and the hospital district regarding transfers. Since May the 12th, we've actually did 4 transfers from Glen Rose. So we still do the backup for them when they're not available, and I think McCon's even done a couple as well. We would like the opportunity to continue what we've been doing for the last year and a half. I think we've provided good service. We are close by. My service is adding a 5th truck. Should be up and running by the end of June to give us additional resources to come in and back up what we already have. Plus, we have the Plantation right next door to us that has agreed to back us up if we can't come in a timely manner. We've not turned down any transfers. We do delay transfers. I also have a contract with the local hospital in Granbury to do the same thing, and it's quite busy. And I do have a contract with them, so they do become priority. My goal is to make sure that the individual patient gets taken care of as fast as we can and as quick as we can. And I know we've had some patients that get flown because of their acuity level, and sometimes when the clouds are in the sky, the paramedical doesn't fly. So you rely on the ground. Like Patrick said, I think it's a real emotional discussion between the 2 entities when it comes to the transfer service. And either an RFP or agreement or whatever means that the county and the hospital district select to determine the EMS, we'd like to be involved with. So we've been in business for 21 years, going on 22 years in Hood County as the 911 provider. We're not going anywhere. We plan on being there for many more years. So we're close by. We mutual aid for Brian and his department when they get in a bind. We're not that far away. We're actually moving a station out 144 a little closer to this direction in the near future. So to me, Somervell County is within my 911 response in Hood County, so it's not that far off. So we appreciate what the hospital's done for us, and we hope we've done a good job. So that's it.
Have any questions at all for Mr. Reeves?
Ricky, my question for you was, and I threw it out there last Commissioners Court meeting, kind of the parameters that you lined out for us to get a contract going. Would you mind letting everybody know that's here with those?
So what I proposed to the county was we would look at some type of annual subsidy to help offset the actual capital equipment outlay that we would do over a 5-year period. And then we would like to look into an agreement as payer of last resort, what Patrick mentioned. It's kind of a normal contract amongst facilities. We have that with Lake Granbury. I think when I looked at those last year, there were quite a few that payer of last resort would have ended up costing somewhere around $30,000 to $35,000 is what it would have cost the hospital that year for those patients that did not have any way to pay. So it's not a real costly contract. We want to try to do everything we can to collect what we can from whomever, and we do that now with our facilities and very successful at it. So the capital outlay, we were looking at a 5-year opportunity that helps us offset the cost. Like Patrick, I'm not. I have a governing board that manages me. We're not subsidized by the county, so we don't have any powers to be that we have to answer to other than my board. So again, I can't outlay a lot of capital equipment to another county without some type of way to offset that. And that was the additional cost that we outlined per year.
Any questions at all? Comment? Yes, sir.
Hey, you said in 22 y'all did 150,000 or
Yes.
so in revenue. Out of that, how many transfers did you do in 22?
201. And this year, we've already done 101 this year. And I haven't, the way EMS gets paid, it's not calendar, so it may be 90 days to see money from the initial payment that we get, so it's always a revolving 90 days after the initial transfer to seeding funds. So I don't have the 23 numbers yet.
Any other questions, comments? All right, thank you, Ricky.
Thank you, Judge.
Thank you.
All right, item number 3, discuss and take action on GRMC patient transfers, which, after listening to all of our options here, I don't know if y'all are ready to
Absolutely not. I mean, I think it's something we do need to put out
to
for
absorb
RFPs.
and talk and sit down with Brian and his group. And so right now, Michael, this, if I say this wrong, y'all correct me, all right? Right now, we've got Texas EMS, we've got, I know Patrick's just temporary, that's 90-day temporary, and then we have Pecan that has agreed to back you up.
Yes, sir.
And then we have our group that backs up Con and you at the end of the last resort, which apparently that hasn't been working out 100%. Michael, would you like to say something?
My only concern, I mean, right now we're able to transfer patients. The only concern is the time frame. Whichever service, we're outside that 30-minute window for our trauma designation in most cases. So until we get to the point of putting a truck in Somervell County or nearby, we will not be able to get our level 4 trauma designation. Still hinders that. But other than that, currently we are getting transferred. You know, we might have to make a few phone calls, but we find somebody available that can transfer. And that's why we have so many agreements, because we never know when one's busy, we try to go to the next one.
We'd like to see something come to a head, 30, 60, 90 days and be done, right?
It would be nice to go. I mean, there is stuff that we're not able to take because we don't have our trauma designation. If there's a trauma patient, they really, without our designation, we have to go to they need to be transferred to another facility. So as we grow the hospital, that's one of the services we're wanting to bring on. We're increasing our level of acuity within the hospital, so that is something that we would like to pursue. There's a lot of paperwork and a lot of things. I mean, there's state surveys and things that go with that. So we got to be able to show that.
All right.
Judge, if I could offer a comment on the trauma designation.
You bet.
In our 5 counties, we serve 3 hospitals already. Our own, plus the hospital in Lampasas, and the other one in Lano. All 3 are level 4 designated trauma centers, which is what Glenrose was trying to re-achieve. They were that at one time. When they don't have the ability to get a patient out the door in 30 minutes or less and documented ability and proof that they're doing that, then they don't get the designation, and they're leaving uncompensated trauma care funds on the table. That's actual real revenue that the hospital is not able to collect because of that. So there is a financial impact as well as a patient care issue as well.
All right. Any other questions? Comments?
Judge, could I?
You bet.
So one of the things I think, and I know Michael's looking at a dedicated unit for the hospital. One of the things I think you need to understand is maybe the cost of what it takes to put one of those units in. Just the personnel alone is going to be $500,000 or more, just for the medics and the benefits. And the unit itself, it's a one-time purchase, but you have an ongoing purchase. It's $500,000 or more. So it's going to be $1 million just to put one ambulance there if it never turns the wheel. And then you have the expense on top of that, fuel and maintenance, and then you got to house them and all that kind of stuff goes with that. So after the initial outlay, you're looking at $650,000 a year just to keep an ambulance running. So an ambulance dedicated at the hospital and doesn't have a transfer for 24, 36 hours is a lot of wasted money that you're going to spend that you're not going to turn a revenue on. To guarantee, and then if that truck leaves and 15 minutes later you get another patient in without backup, you're still stuck. And I will tell you, Lake Granbury is a level 4, and there are times that because we can't unload my county to transport everybody that needs out, and they get delayed an hour, 2 hours, 3 hours. If they're that critical, we try to plow. So there are those delays, and it has not impacted their level 4. I understand what you're going with that.
And that was part of our first discussion and why we were looking to the county to do our transfers, because to the taxpayers, it makes no sense for us to put a truck solely,
Right.
I mean, the hospital could purchase a truck and staff a crew, but, you know, for one transfer a day, that's not, for the taxpayers, that's not feasible. I think there's better options.
And that's why we're increasing our number of units, because Lake Granbury and Glen Rose both, are beginning to move patients out. We're getting more people to come into our territories, and we're getting busier, and we have the 911. I mean, our population in Hood County is about 65,000 we're serving, so, we do a tremendous amount of transfers out of there. And so, there are times they get hit. A couple weekends ago, I think you guys had a critical patient, and we got hit with 5 or 6 transfers at one time. And that's why we need the backups from whomever, because there are gonna be those days, and it happened to be raining, and, helicopter did fly. So, those are gonna happen. So even Brian was to get another unit and do it, he's still gotta have backup, or he's not gonna be able to do it. I mean, always you wanna look at the local, but again, at some point, the cost and the number of volume to recoup that cost sometimes begins to get in the way, and you have to look at alternative methods.
All right. Anything else, guys, on this end? Thoughts, ideas? Where you wanna head, what you wanna do? I think everybody's probably in agreement, and correct me if I'm wrong here, 30, 60, 90 days, we wanna try to come to some agreement with somebody somewhere, so we don't have to keep doing this over and over and over and over and over. We put it to bed and we figure out a way, and if it doesn't work, then we do something else. So, are y'all wanting to take action today? Are y'all not gonna take action and do some more research before you make a decision? What y'all's thought process and input? Don't everybody jump at once.
I suggest we take no action for today.
I'd like to review it for a little bit.
Do some more research before you jump off? Okay. So there'll be no action taken on item number 3, is that the way I understand it?
Yes.
Okay. We'll address it again. We'll see where we go and what we do.